Welcome, this is Dr. Howard Benedict, and on today's session, we're going to be discussing stress and the role that stress plays in chronic disease. We're going to try and give you an idea of what stress is, what the different reactions in terms of how it impacts other systems in the body. So we're going to look at a lot of things that I think will be very beneficial to you in terms of evaluating patients that are in your practice. And of course, the whole goal of this is to optimize the results that you get and achieve better clinical outcomes. So we have a very heavy agenda today. We're going to look at stress and we're going to talk about the Cellier's general adaptation syndrome. We're going to look at the relationship between stress and the nervous system. Of course, we're going to look at the role of stress in chronic disease, stress and inflammation, stress in the brain, or what's referred to as the gut-brain axis, this communication between the gut and the brain, stress in the immune system. How does stress over time impact the immune system? First, how it relates to the innate immune system, and then the adaptive immune system. We're going to talk about stress in the cardiovascular system, and of course, throughout, there'll be sprinkled some clinical pearls that'll help you achieve better patient outcomes. So let's start with discussing what stress is and looking at the general adaptation syndrome, which was one of the earliest models that was designed by researcher Hans Selye of Canada to try and give an understanding of how the body deals with stress. So we know there are really two types of stresses. There's acute stress and chronic stress. Acute stress is an immediate response to a challenge. So something has to be a stressor, whether that's physical, chemical, emotional, or thermal, and then the body adapts to that. And long-term stress, if it's not dealt with appropriately by the various systems that control how your body deals with stress, you can start to develop chronic illness. And ultimately, at some point in time, there will be exhaustion where the body can no longer adapt to the ongoing, what's called allostatic load, meaning your body is designed to handle a certain amount of stress. Life without stress would be pretty boring. So you need to be able to deal with stress, and the adaptation of stress via the HPA axis is something that has been evolving over thousands, if not millions of years, in terms of how a species, in this case a human species, adapts to stress. And obviously it's important for the clinician to understand, is the patient who's in your office dealing with an acute stress or is it a chronic stress? And that's why it's so important. And when I teach nutritional assessment, or in the module having to do with clinical assessment, I stress the importance of going way back into the patient's history, because we now know that even early changes in how the body deals with stress, meaning adaptations to the HPA axis, can start at a very early age. More importantly, that stress can linger on for many, many, many years. The debate has always been, does someone need to have one acute traumatic situation that will ultimately lead to long-term symptoms, meaning being in a war, having something traumatic happen to them, be a part of 9/11 and witnessing what took place in Manhattan on that fateful day? Or is it something that is over time, whether it's a physical ongoing adaptation, or should say maladaptation? So it's very important to understand, is this patient in front of you dealing with something that's acute, or is it something that's been going on with them over a long period of time? And of course, to put this in context, and this is the cover of Hans Sellier's book, which I certainly recommend each and every one of you, if you have never read this book, it is an interesting overview of how the body deals with stress. And Hans Selye was a researcher in Canada, And he noticed when he placed laboratory animals in very stressful situations. Usually, when they test these kinds of models, it's being done in cold water. But let's say putting them in a maze that they couldn't get out of, or giving them a task that they couldn't be successful in, what would happen? And what he proposed is that the body goes through a three-step process, which he called the alarm phase, the adaptive phase, and ultimately the exhaustive phase. And this has been used for many, many years to understand how the body deals with stress. So, as I said, he designed it in such a way that he labeled the three different conditions that the body would go through over this period of time as the alarm phase, which we all know now is the fight or flight response, which is the activation of the HPA axis. Then the adaptive phase, where the body tends to adapt to whatever stressors it's facing on a regular basis. But ultimately, that prolonged stress can alter so many systems in the body that the body can't handle this load, or what's referred to as the allostatic load. So it's important to understand also, where is your patient in this general adaptation syndrome? I mean, for most of us, we're seeing the patient, for the most part, they have a diagnosis and they're probably in that adaptive phase. So we know that stress is basically, if you look at it to define it, it's how we act or feel under pressure, whether it's physical, chemical, emotional, we feel threatened. And this is the typical, your heart rate goes up, you sweat a little bit, the hair on the back of your neck stands up, cold and clammy, heart rate goes up, and this is the initial response to stress. So a lot of systems in the body actually go down in terms of their functioning initially for a short period of time before things start to escalate with the production of inflammatory hormones such as cortisol. It happens when we're in a situation we feel we can't control. And of course, that's a difference in the sense that everybody handles stress differently. You can put 2, 3, 4 people in a stressful situation, and everybody might react differently to that. Small amounts of stress can help us to complete tasks and feel more energized, meaning we're in our office every day seeing patients, so that's stressful. We're handling phone calls, we're taking care of insurance, we're seeing patients, we're doing all of the other tasks that we have to do in a day-to-day basis in terms of running our practice. So some stress is good. The problem is if you don't combat it with the opposite part of the autonomic nervous system or the parasympathetic nervous system, which is the rest and digest, you have a problem because you become more sympathetic dominant. That's the gas that's driving this whole inflammatory response. And as we'll see later on, stress feeds inflammation, and inflammation feeds autoimmune disease, systemic inflammation, neurodegenerative disease, issues in the gut, issues with the heart, uh, induces dysbiosis in the gut, which can further lead to intestinal permeability. So you have these feedback loops constantly working, and it's the job of the clinician when you take your history to figure out for yourself, why does this patient who's sitting in my office, why do they have these complaints? And how am I going to go about managing them? I mean, for instance, I had a patient in my office the other day who came in because he was suffering from cervical spine pain. It was a sudden onset following some exercising. Although he's been weightlifting for many, many years, the history that he tells me is that he was doing something and he suddenly heard a snap. And when I asked him, did you change anything? Well, it was the first time he was doing the reps the normal amount of reps with a higher amount of weight. So in the course of the consultation, he starts asking me questions because he has other issues, such as anxiety, depression, sleep problems, gastrointestinal problems. He showed me a surgical scar where a part of his colon was removed, and he wanted to know if there was any correlation between his gastrointestinal symptoms and the fact that he's constantly experiencing muscle symptoms and muscle tightness. And this is something we're going to investigate, but you can begin to understand how complicated and complex not only is the human being, but how different symptoms can affect or be the result of various systems in the body that supposedly should work together that have had a problem in terms of how they do that. So a chronic stressor exposure causes body weight changes, and the long term can be detrimental, which we should realize. The longer someone's under stress, the longer they're suffering from anxiety, the longer they're not getting good quality sleep. It's like a snowball rolling down a hill. It's picking up momentum. So more things either can help initially, but over time, you'll begin to see that that patient responds totally differently to a stress or stressor as they had in the beginning. So micro stresses can lead to obviously dysfunction. And it's not just the HPA axis, the hypothalamic pituitary adrenal. Always consider HPA axis to be in alignment with HPT axis, hypothalamic pituitary thyroid, and hypothalamic pituitary gonadal. And that's always something you should keep in mind because these systems do integrate the same way. Later on we'll talk about the adrenal glands, but the adrenals don't work by themselves. I mean, granted, they have a cortex and a medulla, and they produce epinephrine, norepinephrine, and cortisol, but the adrenal glands work in conjunction with other organs to create a system that's helping the body deal with blood sugar regulation, stress, uh, the ability to stand up properly, to get good quality sleep. So there's a lot of symptoms that can result from adrenal dysfunction. There are many articles that talk about adrenal dysfunction as it relates to long COVID patients because of the fatigability that's found in these patients, which I'm sure any of us who treat a lot of long COVID patients will see a major complaint is fatigue. Now, whether or not that's coming strictly from HPA axis alteration and high cortisol, is the fatigue coming from mitochondrial dysfunction, excessive reactive oxygen species being generated, exposure to environmental. So I'm going to assume that it's a combination of several different things that are ultimately creating that or working together. So we know that the alarm reaction, it's the body's first response to stress. And the stress triggers the fight or flight response. And that's when the body has to make a decision what it needs to do or what it's going to do. And certainly we can relate to that when something has to be done. It needs, which is kind of not talked about so much, but it needs the energy to do what it's supposed to do. If you don't have good mitochondrial function, then you honestly don't have anything. There are obviously hormonal changes, and depending upon which part of the adrenal glands are involved, it's either going to be producing cortisol and adrenaline and norepinephrine to get the body awake in terms of dealing with the stress. So in the resistance phase, what happens is the body adapts to the stressor, and the body continues to produce stress hormones, but at reduced levels. It's reflecting its adaptation to whatever is causing the stress. And functionally, in this particular part of the general adaptation syndrome, the body still functions, but it's constantly adapting to the stressor and having to deal with. So let's say you're dealing with high sugar. Your body's going to continue to adjust and produce more insulin, but over time, there is going to be obviously problems in developing, not so much with producing insulin, but the type of insulin and other factors may lead to ultimately what's referred to now as insulin resistance. So in the exhaustive phase, this is where the body is totally depleted of resources and the body just can't deal with the allostatic load that the body is presenting. And it's at this point where things start to break down, both physically, mentally, and in terms of just how the different systems in the body are going to respond. So here we have a chart that shows, and this is from Cellier's work, the alarm phase, the resistance phase, and the exhaustive phase. And what you should notice that over time, initially, you'll see whenever there is the alarm reaction, it'll activate a part of the immune system and the endocrine system where there's actually going to be a drop in certain chemicals that the body will produce in response to the stress. But over time, you can see the curve that develops because you're shifting into HPA axis activation. And this is the crucial thing to concern yourself with, not only in the patient, but in terms of your history taking. Because many patients, you really have to delve into their history and see what their previous health history was like as a child. Were they sick a lot? Did they have antibiotics? Were they premature? How were they developed? Were they vaginally produced, developed in terms of their delivery system, or was it a C-section? So you're activating your HPA axis, you're driving more cortisol levels, and ultimately you see at some point the body can no longer handle this resistance phase to the stress or stressor, and suddenly you have adrenal exhaustion. So this is a slide that you can see how various parts of the body, as far as the central and peripheral nervous system, the enteric nervous system, which is part of what's referred to as the second brain, which are nerves that supply the various organs, part of the digestive system in terms of the small intestine and large intestine. You see the systemic immune response, what happens to the gastrointestinal mucosa, and ultimately the gut microbiome or gut microbiota. I mean, certainly we know in an acute phase, we already realize certain things are going to happen. And you can see on the chart that there's going to be a release of these adrenal hormones, norepinephrine and adrenaline, which feed the fight or flight response. Then ultimately, you're going to get a release of corticosteroids. So what this is really saying is a certain amount of stress is okay, an activation of the HPA axis, and of course the innate immune response is normal, but over time it's not normal. And what can begin to happen is there's this delayed response. You can see as far as the central nervous system, you start to activate some of the stress-related neuronal circuits. You start to develop more inflammation. That inflammation ultimately leads to neuroinflammation, which then relates to a breakdown of the blood-brain barrier, and that creates microglial activation, and that's when you start to experience things like anxiety, depression, brain fog, and that all gets worse over time. you can see that you're affecting now that part of the autonomic nervous system referred to as the parasympathetic nervous system. And in particular, you're affecting the 10th cranial nerve, the vagus, which is something I've talked a lot about, since the vagus controls a lot of the functionality in the gut, the peristalsis in the gut. If you slow down peristalsis or the food going through the intestinal tract, you start to increase the probability of dysbiosis. And certainly when you lose vagal tone, a whole host of metabolic problems uh, can be created as a result. And I certainly invite you, we're going to talk about later the vagus nerve and things that you can do. I have found this to be very, very helpful in my clinical practice in helping patients who are dealing with chronic stress, especially patients who are suffering from obviously chronic fatigue syndrome, long COVID. You can see what happens to the immune system, and that stands to reason that over time, the longer a stress is being dealt with, and certainly with age, the immune system doesn't work the way it should. You start to lose the integrity of natural killer cells. You certainly lose the ability of Th1 helper cells, so you're more prone to infections. So it's a gradual decline, not only in the immune system, but just about every part of the endocrine system is part of the aging process. Mitochondrial dysfunction, and you can see how when we talk about the mucosa, and this is an area that I think is neglected in nutrition, the mucosa is the covering, so it's an additional barrier to the epithelial cells. And in the small intestine, the mucosal lining is one layer thick. In the large intestine, it's two layers thick. So once that starts to break down, and within the mucous membrane lining are antimicrobial peptides, and of course, secretory IgA, which is an important immunoglobulin that helps the body fight off infection. So we talk a lot about intestinal permeability. Just think of the mucus as being another barrier that helps to prevent toxins, whether environmental toxins or endotoxins, from getting through. But over time, what begins to happen, you start to develop more of a reduction in the mucous membrane lining. You increase permeability in the gut. Remember, nutrients get through into the bloodstream either transcellular, between cells, or paracellular. And what begins to happen is you lose that ability to control the flow of toxic material into the intestinal cells, and then ultimately it's going to traverse into the circulatory system and drive the immune system to produce pro-inflammatory cytokines. You're going to get dysregulation of mast cells. So mast cells are all over the body. They produce histamine, and when they get broken down, they release a lot of enzymes that are naturally anti-inflammatory. So when you get that into the system, that's driving inflammation. And we know that as people age, their gut microbiota change, not only the amounts of bacteria, but the quality of the bacteria, and more importantly, the diversity of the makeup of bacteria. So we know that there's a lot of different families of bacteria in the gut, but the problem is over time, that diversity changes, so it kind of switches into a situation where you have more pathogenic bacteria in your gut than good bacteria, and that creates dysbiosis, which then can lead to even more permeability. So we know that within the stress response, the endocrine system is involved. It initiates the stress response, as I said, with the production of adrenaline and noradrenaline and cortisol. So we should all be familiar by now with the HPA axis, where activation of the hypothalamus, whether it's through a physical stress, a chemical stress, or a thermal stress. And I point this out in the sense that trying to understand what's causing the stress response, the mechanism of this is the same. So it leads to the production of adrenal corticotrophic hormone, which ultimately helps the adrenal glands to produce the stress hormones through ACTH, adrenal corticotrophic hormone, releases within the cortex cortisol. So you have adrenaline, which is part of the flight or fight response, and then ultimately cortisol kicks in. So we know that activation of the HPA axis from stress activates the sympathetic nervous system. That is the fight or flight response. And we know that as a result of that activation, there are a number of different changes, and that long-term activation, prolonged activation of the the sympathetic nervous system can lead to a whole host of problems physically and mentally, or I should say physiologically and mentally. We've already talked about changes that take place within the immune system itself in terms of the innate immune response and the adaptive immune response. Remember, the innate immune response is very quick acting, it's non-specific, it doesn't have any memory at all, whereas the adaptive immune responses, majority of it is through antigen antibody. It's very long term. There's memory. Your body's producing antibodies, and it's regulating the type of T cell response that should happen as it relates to the type of reaction, meaning the body has to determine whatever is activating the inflammatory response, which is driven through stress, either by some pathogen or some damage associated molecular pattern, like tissue breakdown, trauma in a joint, ongoing degeneration leading to inflammation, autoimmune disease. The body has to determine what type of response happens there. So we know that there are certain psychological responses to stress, and this is a major problem going forward with a lot of patients. Where do you separate the whole or bring into play the whole mind body? That we know that stress and inflammation activates the sympathetic nervous system, which activates one of the major transcription factors called NF-kappa B, which then drives, because it's a transcription factor for inflammation, and that inflammation releases then cytokines, and these cytokines drive anxiety and depression in the gut, which is the total package in terms of understanding this gut-brain axis, which has become so popular in the last 10 years of overview. So we know that there are certain chronic diseases that are linked to prolonged stress, like heart disease, diabetes, obesity. I mean, most of these problems, chronic respiratory diseases, all have an underlying keynote of inflammation. So inflammation plays a big role in managing these patients with maladaptive stress responses because the stress is driving inflammation. So we can see here that stress elevates adrenaline and cortisol levels. It depletes nutrient stores, especially water-soluble vitamins. It compromises the immune system. We said that stress drives inflammation, and it leads to low-grade chronic inflammation. So if you looked at a chart and you looked at an acute inflammatory response, certain biomarkers, especially IL-6 and HSC reactive protein, high sensitivity C reactive protein, in an acute flare-up are elevated and then come down to baseline. In a chronic inflammatory situation, high sensitivity C reactive protein and IL-6, which is a very, very pro-inflammatory interleukin, stays high. It doesn't really go down to baseline. It may be high enough whereby maybe the person doesn't experience any symptoms, but it's still ongoing low-grade inflammatory. And ultimately, that will cause, as we've already spoken to, damaged tissue, organs on a cellular level, and that inflammation further drives a stress response. So if you're really unpacking this all, you have certain areas of inflammation that keep driving, meaning stress activates the HPA axis. Activation of the HPA axis drives inflammation. Inflammation drives autoimmune disease. Inflammation also drives dysbiosis in the gut. Dysbiosis in the gut causes more inflammation. That breaks down the gut barrier. The translocation of pathogenic bacteria into the circulatory system drives more inflammation. Enough inflammation drives neuroinflammation. So there's a lot of pieces to this puzzle, and that's why patients who come in when they're chronically ill, it's not just one system that you have to deal with. It would be very easy to approach this by saying, well, I just have to give some adrenal support. If I address the adrenal glands and whatever I'm going to do with the adrenal glands and give them a protomorphogen, put them on an adrenal product that a vitamin company sells, that will be enough to get this patient uh, to be feeling better and stopping the progression of their stress and inflammatory response. Well, that's not the way it works. Obviously, you can tell already that you have to deal with a lot of different systems and kind of create your own algorithm in terms of how you want to deal with this patient. Is this something you want to straighten out their immune response? Is this something you want to go ahead and do their look at their liver detoxification pathways? Is this something you want to do to lower their inflammatory response? Is it gut repair? Is it lining? Is it healing the lining of the intestinal tract? Well, I can only tell you over many, many years of clinical experience. I mean, I've been in practice almost 50 years, that I used to think that it's all about the gut and healing the gut. And we'll talk about protocols for healing the gut and healing the lining, the intestinal mucosa, and healing epithelial cells. I'm beginning to think more and more what's just as important is managing that patient's immune response, not only their innate immune response, but their adaptive immune response, making sure that the T cells that get produced in lymph nodes, so T cells mature or come from bone marrow into the thymus. And this is one of the things that Hans Selye pointed out in patients or in his animals, laboratory animals, that after prolonged stress, and he autopsied the lab animals, he noticed that there was hypertrophy of the thymus gland, that the thymus gland had become more laden with fat, meaning it wasn't able to produce enough T cells. Those T cells go to the lymph nodes and are sitting in the lymph nodes. And when certain cells called dendritic cells carry the debris or the information, whatever it's been called upon to phagocytize into the lymph node, that's when a decision is made what type of T cell needs to be cloned. Is this the type of T cell that needs to deal with something that's very small, like a bacteria, a fungus, or a virus? Or is this something that's much larger? And understanding what type of T cell response your patient has. Is it more Th1 dominant, which has to do with intracellular destruction and phagocytosis? Or is it more of a Th2 type of response, which would imply something bigger that can't be digested intercellularly, but has to be dealt with extracellularly outside of the cell? And that usually leads to inflammation in hollow spaces. So patients who come in with asthma, allergies, food sensitivities, sinus problems, difficulty breathing. They have lung problems, um, infections in their intestinal tract, in their vaginal tract, in their bladder. All of these infections in hollow spaces implies a Th2 type of response. The significance of that is when a person is constantly being stressed by viruses or bacteria and their Th1 response is lowered, Th1 cells control a type of T helper cell called a Th17 cell, which drives inflammation and ultimately drives autoimmune disease. So that's why over time, when a person's innate immune response isn't as strong as it should be, as you age and cells go into what's called senescence, you lose that control. And that's why we're seeing now an upsurge in autoimmune disease, and usually there's a higher rate of autoimmune disease in women as a result because of hormone changes. But that is another side effect of prolonged infection and not having a strong innate immune response. So we know that inflammation is the common pathway, that most conditions that you see in your practice, an underlying theme is inflammation. So understanding what inflammation is, but more importantly, what is causing the inflammation is more important. I think a lot of us, I know medical doctors are only driven by, you have an inflammatory situation, we're going to give you a corticosteroid or some steroid because that is going to reduce your inflammation. And there are a lot of practitioners who use supplements. There are numerous supplements that can be used to reduce inflammation. It's not resolving it. So you're not looking at the underlying cause and trying to find out what's driving the inflammation, but the patient will feel better. Of course, your goal, I would think, to be educate the patient to make better choices such that you prevent further progression of their illness. So this is a chart that I use for teaching that shows the inflammatory pathway. We'll make this very quick, but something has to initially turn on the innate immune response. So remember, the innate immune response is very nonspecific. It's not made up of these fancy cells. It's usually things like hydrochloric acid in the gut, tears, inflammation. The complement system is part of the innate immune response. The tearing of eyes, it's very nonspecific, whereas the adaptive is more T cell, B cell. And you can see when something activates an immune response, whether it's a pathogen or some type of trauma to tissue, it suddenly creates the production of these adhesion molecules to attach to the inner surface of very small blood vessels. And those adhesion molecules attract first neutrophils, and neutrophils, because there's more permeability in blood vessels, and this is of major concern for any of you treating long COVID patients, this leakiness of blood vessels, like leaky gut, leaky brain, leaky lungs, leaky blood vessels. Increased permeability of blood vessels attracts not only more neutrophils, but ultimately macrophages will come in. And it's the macrophage's job to kind of clean everything up. And they present that information to dendritic cells. And dendritic cells are what takes the information into the lymph node. In order for that to fully happen, though, properly, there has to be, if you notice in the middle of the screen, there is a traffic light. There has to be something called lipid mediator switching. And this involves omega-3 fatty acids. Now, we're all familiar that EPA and DHA are important anti-inflammatory molecules. EPA reduces inflammation. DHA will do it also, but DHA is more involved when you're dealing with neuroinflammation, anything having to do with the eye, more DHA than EPA. And we know that the American diet, most Americans don't eat a lot of fish in their diet. You can actually check this in your patients by doing what's called an omega index, which is just a skin prick test that will tell you how much omega-3 fatty acids a patient has, not only in their bloodstream, but it's an indication of the amount of omega-3 fatty acids in cell walls. And cell membranes are very important for controlling how nutrients enter the cell and how nutrients get into the cell. And that's dependent on there being membranes that are not stiff and have aged out. What EPA and DHA do also is they convert into a chemical called a pro-resolving mediator, or in the literature they're referred to as specialized pro-resolving mediators. SPMs are 100 times more anti-inflammatory than EPA and DHA. And in patients who have long-standing chronic inflammation, rather than giving them EPA or DHA, which would be fish oil, you can supplement them with these pro-resolving mediators, the purpose of which is to resolve the inflammation. That is a big difference from reducing the symptoms, the usual redness and swelling and stiffness and pain on motion. You're actually talking about getting the area back into what's called homeostasis. And you see on the slide, what are some of the signs of resolution of inflammation? You're producing more pro-inflammatory. You're getting rid of all of the pro-inflammatory cytokines, and cytokines are just messengers of inflammation. You're starting to repair the damaged area. You're getting rid of neutrophils. Now, this may not seem significant, but in patients who have long-standing swelling in joints, that usually implies there's not been adequate resolution of their inflammation, because you also want to get rid of the inflammatory tissue that's in the area. You want to clean that out, because if you don't get to that level of resolution of inflammation where you have a normal T cell and B cell response, you go to the top of the chart and you start to have more chronic inflammation, and the chronic inflammation leads to fibrosis in tissue, and with enough fibrosis in tissue, then you have organ damage. So it's always about trying to get from an inflammatory state to go through the process, and we know that inflammation is a very well orchestrated phenomena that the body has built into it. And a certain amount of, or seeing someone's inflammatory response work the way it should, is actually a sign of their overall degree of wellness. Because inflammation is a good thing to have, but if it doesn't resolve, now you have long-standing, as I mentioned before, low-grade inflammation that can lead to damage, long-term damage to tissue and ultimately organs. And these pro-resolving mediators protect, in particular, neurons and other parts of the central nervous system. So you always want to think about, when a patient is in a state of inflammation and you're doing your blood work, where are they in the process? And more importantly, what's causing the inflammation? Is it a pathogen, which would be referred to as a PAMP, a pathogen-associated molecular pattern, or is it a DAMP, a damage-associated molecular pattern? The significance of that is we've all taken histories on patients who come to us, and let's say they have cervical spine pain. And in your history, you'll ask them, well, have you ever had trauma to your neck? Have you ever been in a car accident? And they will say, yes, I was in a car accident years ago, or I've been in several car accidents, but it was treated, the pain went away, and I was fine. Well, that's not the way it works. Just because the pain has gone away, the underlying inflammatory response is still going on. So that can be an activator of this whole inflammatory process. But the goal is always to try and get to homeostasis. So we know that chronic inflammation is a failure of resolution, that inflammation is evolved as a protective response to any insult. It's a primordial response over millions of years that encompasses an endogenous anti-inflammatory mechanism. So this is going to happen. The problem is when it's not resolved appropriately. And as I said, this is well orchestrated within days, meaning the immediate response is within minutes to ultimately hours. And subsequently, within 7 to 10 days, any type of insult should be resolved. It's when that doesn't happen and that time frame is projected out longer than it should, that's when the problem exists for a patient, where they have a chronic disease that underlying it is long-standing chronic inflammation. So we know that inflammatory responses result or is an underlying statement to a large percentage of illnesses that exist, that this can have a result in problems in just about every organ in the body, every system in the body can react over when there's a long-term non-resolution of inflammation. So is it a friend or a foe? Well, you need to have inflammation. It needs to work the way it's supposed to. If it's not resolved and you have low-grade inflammation, that's a problem. And we can see that acute inflammation can lead to chronic inflammatory conditions, cardiovascular disease, autoimmune disease. Remember, I said that inflammation feeds autoimmune disease given enough time. That's why, and it's not unusual to see a patient present in your office with not only one, two, sometimes even three. I think I've seen a patient with 4 different autoimmune diseases. So you need to educate the patient that this has happened over time. And more importantly, you have to assume that from acute inflammation with non-resolution in the 20 to 25 year age to develop, obviously, things like cancer, rheumatoid arthritis, fibromyalgia, and obviously now we're seeing more and more chronic fatigue syndrome. And the presentation of patients with chronic fatigue syndrome with adrenal dysfunction and more importantly, issues with mitochondrial dysfunction mimic in a large, in a very big way, long COVID symptoms. They're not the same in the sense that chronic fatigue syndrome doesn't have the same disruption of the adaptive immune system as long COVID does, but a lot of the symptoms are very similar in both. So clinical questions to ask in terms of management of a patient with inflammation is really you need to understand what's causing the inflammation. Because if you don't understand, is it their genes? Is it because they have unresolved COVID-19? They have spike protein, and we know that the studies have shown that the protein can live a very, very long time in individuals if it's not handled properly. Is it stress that's feeding the inflammation? Is it their diet and lifestyle? They don't get enough sleep. They don't have hobbies. They don't have friends. They don't do anything proactively. And that ultimately leads to unresolved massive inflammation that can lead to a whole host of problems. But the underlying concern is always try to understand what is causing the inflammation as opposed to treating the inflammation. So once again, as a review, there's always going to be some kind of trigger, whether it's a pathogen or some type of damaged associated molecular pattern. It's going to activate certain types of immune cells. Initially, neutrophils and macrophages, and I said dendritic cells are these presenters of the information into the lymph nodes, but ultimately you're going to get the release of pro-inflammatory cytokines, this cytokine storm that we know so well as it relates to COVID-19 infections. There's going to be vascular changes or increased permeability, which I talked about, permeability in the very small blood vessels. There's going to be recruitment of various types of cells that are going to go to the area of damage. And it's going to be the job of macrophages to destroy and clean up the area and get this information into the lymph nodes so it can be really gotten rid of. You don't want to have cells floating around in your tissues that once again can act as a nidus for more inflammation. And of course, you want to get through resolution. You want to resolve the inflammation with nutrients, diet, lifestyle changes, and it's not unusual. I have many patients, long-standing problems like migraine headaches, skin problems, the gut-skin axis. Headaches is a classic one where I would consider using the specialized pro-resolving mediators and to get the body into a more homeostatic state by driving more anti-inflammatory signals to help promote healing, for tissue repair, etc. So what are some of the molecules? We've already talked about a lot of these cytokines like IL-1 beta, TNF alpha, and the big one to be concerned about is IL-6. So you have cytokines and then you have chemokines. So chemokines are cells that are attracted chemically to an area of infection and inflammation or injury. There are prostaglandins, reactive oxygen species, then that's why taking or being on a diet that's very high in fruits and vegetables, a more plant-based diet, and I would refer you to the work of Dean Ornish, who has done exceptional work in how plant-based diets deal with cardiovascular disease, prostate cancer, and his latest report looked at lifestyle management of patients with Alzheimer's disease. And he was able to prove with the right supplementation and lifestyle, i.e. diet, that you could stop the progression of Alzheimer's disease. And of course, controlling the complement system. And the complement system helps to label pathogens and identifies them for destruction. And if your complement system isn't working, which is part of your innate immune response, you have issues. And this is the chart that I've been talking about, where you see in the initial acute inflammatory response elevations in IL-6 and CRP. And most of us do this. There are certain biomarkers, which we'll talk about, which you should be doing in your as part of your lab, as opposed to doing a standard CBC, SMA21, and urine. There are certain additional tests that I usually run on every patient, but you can see in an acute phase, sprained ankle or lifting something, and they come into your office, there'll be an elevation of IL-6 and CRP, but then over time, within that short window of several days, those levels go down. But you see in an acute response, where there's a chronic response, where there's failure of resolution, IL-6 levels and CRP levels are higher, and they stay that way over long periods of time, and that drives chronic unresolved inflammation. Here you can see the typical stress response, where stress is activating the HPA axis, and once again, that stress could be chemical, external, air pollution, smoking, chemicals in the workforce, people who work at jobs where they come in contact with gasoline and all kinds of other chemicals. We know that plastics are a major driver of inflammation now. And what can happen, whether it's from a pathogen or from previous trauma. So let's say it's a concussion. So this is really important for those practitioners that have a high caseload of patients who are in auto accidents, because brain injuries drive the immune system into an inflammatory state. It causes an upregulation of macrophages, in the brain, which are called microglial cells, and that drives neuroinflammation, which would result in things like Alzheimer's disease, Parkinson's, dementia, ALS. We know there is a strong correlation between trauma to the head and neck and ALS. That's why there are so many football players, it seems, that later on, after they retire, develop ALS. But you can see the correlation that they produce, you know, uh, corticosteroids, and over time, the more steroid you produce or more steroids that you take, that a patient takes, the cells become actually resistant to steroids. So you need higher and higher amounts. And you see with corticosteroids, you have a negative feedback system. This will also produce very pro-excitatory amino acids like glutamate. And this ultimately will epigenetically turn on certain genes that drive inflammation, these interleukins that drive inflammation. You're going to get an excessive uh, nitric oxide increase and other free radicals that will lead to neuroinflammation. So when you have enough body inflammation, you get neuroinflammation because the glial cells, which are the immune cells of the brain, get activated. And once again, these glial cells have two different types of phenotypes, an M1, which is very, very pro-inflammatory, and an M2, which is anti-inflammatory. So stress will drive an M1 phenotype in the brain. So we know that this is all connected, and more of work is being done constantly on trying to understand this interrelationship between the gut and brain, that 80% of fibers go from the gut to the brain and 20% go from the brain to the gut. And this communication, and that's why I stress it so much when I teach, because I think chiropractors need to understand, if we're going to talk about being specialists of the nervous system, how does the nervous system communicate with other parts of the body? Number one. How does the nervous system communicate with the immune system? How does the gastrointestinal system communicate with the immune system, which communicates to the nervous system? So I think more and more chiropractors should be at the forefront in understanding this crosstalk that takes place. I would certainly recommend you to read a book called Psychobiotics by John Cryon. John Cryon is a leading neuroscientist that has spent the last anywhere from 15 to 20 years studying this connection. And one of the things he talks about, since he teaches at a medical school, is to get other disciplines to kind of understand this communication. I mean, how do you get a GI guy to understand that dysfunction in the GI tract can affect brain chemistry? Or how do you get dysfunction in the GI tract causing dysbiosis as a result of leaky gut or intestinal permeability? How do you get a rheumatologist to understand this connection between the gut and joints? Certainly, how do you get an orthopedist to understand that perhaps lumbar pain and thoracic pain and even cervical pain may not be the result of a compression of the disc material, but what's causing that? And lots of studies have shown that pathogenic bacteria are surrounding this tissue, this disc tissue, and maybe the use of probiotics and prebiotics and postbiotics and fermentable foods can be an alternative to using medication to reduce low back pain or to treat. And the significance is, we know this communication. We know that the digestive system and maldigestion and issues in the gut and permeability in the gut can lead to problems with mental health and overall feeling uncomfortable. And we've all known this. when patients come in and they have the lower back pain and you treat their lower back, and then they start to talk about the fact that their digestion appears to be better, their elimination appears to be better. So we know that this gut brain, which is really at the forefront in the last few years, there are probably more papers written on the gut brain axis, the gut microbiome, uh, than anything else. I mean, I read somewhere that over 100 different papers a week all over the world that they're studying the significant role that the gut microbiota play in health and wellness. And I think chiropractors should start to learn more and more and more about it, and what different types of probiotics and other things can be given a patient to help them, not only as it relates to musculoskeletal pain, but their overall health and well-being. So once again, it's the gut-brain axis and the enteric nervous system, which I referred to earlier as the second brain. It's often called the second brain, and it's due to its autonomy in governing digestive systems. So the enteric nervous system communicates with the central nervous system, forming the gut-brain axis that influences our overall well-being. So there are numerous tests or papers that have been produced that altering the makeup of the gut bacteria, which ultimately affects the genes that are in the gut. So we have about 3.5 million genes in the makeup of bacteria that's in the gut, which is accounting for not only viruses. We tend to think more and more about viruses and bacteria, but there's a lot of interest now on the levels of different types of fungi that are in the gut. So I just want to explain, even though the terms are thrown around, the microbiota refers to the amount of bacteria that exists and fungi and viruses, whereas the microbiome is the genetic information. So we have about over 27,000 genes. The number of genes in the gut is about 3.5 million. So we are more bugs, so to speak, than we are actually human cells. And I think what's interesting is the gut microbiota weighs about 3 pounds, and that's exactly the weight of the brain. So there seems to be a correlation the same way the brain has a cortex and a medulla, as does the adrenal glands has a cortex and a medulla, one being central to the central nervous system, and the adrenal glands being central to this HPA axis and generally running various parts of the nervous system and the endocrine system. So we know that inflammation leads to changes in the gut, and this is taken from a paper published in 2009. But I think it's important to note, and this is a good clinical pearl to remember, that stress leads to an upregulation of the sympathetic nervous system, which upregulates NF-kappa B, which is the most important transcription factor of inflammation, which ultimately leads to inflammation. And systemic inflammation, I said, when there's enough, leads to neuroinflammation. And some of the classic symptoms of patients that have excessive amounts of neuroinflammation is going to be anxiety, depression, cognitive decline, which are generally, you have to be seeing a lot in your practice, and patients are readily concerned about whether or not their cognitive decline is leading to Alzheimer's disease, and ultimately sleep issues, and of course fatigue. And here you can see the entire scenario of how stress drives inflammation, that changes the tone of the vagus, that leads to changes taking place in peristalsis and more pathogenic bacteria, that increase in pathogenic bacteria leads to the production of certain inflammatory cytokines, which drives brain inflammation. And if you see on top, stress drives HPA axis dysfunction. An important note to note If you look at drugs that have been designed to treat Alzheimer's disease, they've all been designed to try and break up these plaques, these tau proteins that get deposited, these protein filaments that get deposited in the brain. And it's really come down to, in the last few years, of understanding that the reason those drugs don't work is because it's addressing the wrong problem. That the problem is really more inflammatory, and maybe these depositions of various types of proteins, like Lewy bodies and tau proteins, etc., are an attempt of the body to deal with the inflammatory process. So we know that changes in the gut can lead to neurodegenerative disease. And we can see here that stress affects gut motility via the vagus, paracellular permeability, so you get intestinal permeability. It alters the makeup of the gut microbiota, the diversity and the types of bacteria. And what's interesting to note, that diet can very quickly change that. You don't have to get into a lot of probiotics, although it's probably very important. It's also going to affect the amount of mucus. Now, I'm a big proponent of using things like vitamin A and other things to help maintain the integrity of the makeup of the lining, the mucous membrane lining. Remember, in the small intestine, 1 layer thick, large intestine, 2 layers. It affects visceral sensitivity. So this is the mucosal immunity. Remember, the mucosa has like antennas sticking up into the lumen, and it's reading whatever is coming through. And the minute it picks up something that it doesn't like, that activates an innate immune response. So you can see, as a result, things like reflux, peptic ulcers, although we do know now that it's H. pylori. Now, if you remember from the beginning, if your innate immune response or your Th1 response isn't doing what it's supposed to do, and the easiest way to get that elevated is using berberine, 500 milligrams of berberine once a day. When you lose that ability of your Th1 cells to control pathogens that are in very, very small, like viruses, etc., it promotes a loss of the mucous membrane lining. So a lot of the things that we've talked about lead right in. Irritable bowel, so I said that's a type of Th2 response, inflammatory bowel disease. And certainly when you start to lose the mucus covering in the gut, these sensors pick up more things, and you start to develop more food allergy and more food sensitivity. So remember, food allergy is a true allergic response. It's an antigen antibody reaction. And when someone's got things going on that affects their gut, whether it's chemical or emotional, it will affect how that gut responds to things coming through. So, influence of microbiota on mood and mental health. We've already talked about, and that's the work of John Cryon and others. So, where do probiotics fit into this? So, there's certainly an important role that probiotics play. And I think probiotics, in addition to vitamin D and vitamin A, are crucial for maintaining the integrity of not only the epithelial lining of the gut, but the makeup of bacteria in the gut. The problem is, most practitioners or most patients go to a health food store and they buy acidophilus and bifidobacteria. And you'll see when I show you some other slides, those types of formulations get broken down in the acid environment of the gut and don't really get absorbed at all. So we know that the composition is very, very important. Digestion is important. So remember, it's not just the numbers. People come in my office all the time. I bought this, it's 250 billion colony forming units. This must be a great product. But if it's not culturing in the gut, and getting broken down in the stomach, what good is it? So we know as a result, there's this communication. And here you can see even better the communication between the brain and the gut via the vagus nerve. The vagus nerve is cranial nerve 10. It's the longest nerve. It's wandering. And you can see in the slide to the right the makeup of cell membranes. You can see the epithelial cells, the villi sticking down into the lumen. And here you have cells that will respond to what's going on. You see T cells, B cells, hormones that are in the gut. And when there's permeability, there's leakiness of these chemicals that are in the lumen into the general circulation that can drive inflammation downstream. So we know all disease starts in the gut. This is going back to Hippocrates. And here you can see, and this is interesting, how many different systems in the body are connected to the gut. Gut brain, gut heart, gut lungs, gut bone, gut disc, gut muscle. I'm going to be doing a future presentation on a patient with gastrointestinal complaint, intestinal permeability, and eczema. So the gut-skin axis, which you see on the left, the gut-kidney. So the gut is very, very crucial in communicating with so many other things. So here you can see a cross-section of epithelial cells, these tight junctions that were defined early on by Alessio Fasano, who was investigating gluten and noticed when certain individuals were stressed with gluten in their diet, it opened up these tight junctions, and that led to ultimately the understanding or coining of the phrase intestinal permeability. So you have these villi sticking up in the lumen. There are food particles going through. You see secretory IgA, which is an important immunoglobulin, and that's why I use vitamin A. I think it's a vitamin that doesn't get any respect. So certainly we know that tight junctions are dependent upon probiotics, vitamin D, vitamin A are very, very crucial to maintain this mucous membrane, which is really just, as I said, another protection. Because once these pathogens seep through these tight junctions or paracellularly, they get into the bloodstream and they activate this reaction where these nasty chemicals go downstream and cause all kinds of havoc. And this is a test that you can do in your office. It's a skin prick test, and it measures, as you can see, zonulin, occludin. These are the two most important tight proteins. LPSs, which we'll talk about later, and yeast, candida. High yeast, obviously more inflammation in the gut. So you can see this test looks at these markers at two different layers, at the IgA layer and via the complement. Remember, the complement is the innate. So you can see in this patient, they have candida, but really severe because it's deep in their tissues, because the elevation of their IgA 1 and 2 is very high. Zonulin as well, occludin, not so much. And LPSs, lipopolysaccharides, which are derived from gram-negative bacteria, they're very pathogenic. And the higher the LPS count, that breaks down further the gut barrier and can cause inflammation. So I found this, and just to show you how does dysbiosis affect the gut joint, which we should be concerned about as chiropractors, if you are a chiropractor, the interconnection between the gut and joints leading to inflammation, gut dysbiosis and inflammation, you should be aware of. OA and inflammation, so osteoarthritis, which is not a true inflammation. Patients ask all the time, and it's more wear and tear. It's chronic low-grade inflammation, and the gut joint axis suggests Gut dysbiosis can contribute to inflammation and causing more and more damage to joints that are wearing down. Obviously, there's increased permeability, more cytokine relief, and more endotoxemia driving more inflammation. So if you look at nutrients to repair the intestinal barrier, this is a chart that I kind of made up. Glutamine, which I think is really important. Uh, Unfortunately, in this study that I found and created this chart, you see things like glutamine is not rated high, but zinc carnosine, so this is a special form of zinc, vitamin D, omega-3 fatty acids, probiotics, a surprising member on the list, N-acetylglucosamine, because most of us think of N-acetylglucosamine as it relates to joints, but it does heal the lining of the gut. Curcumin, or turmeric, which is very anti-inflammatory. And a note that for many people who take probiotics, their probiotics are acidophilus and bifidobacteria. Some people, because it doesn't get absorbed very readily, or they might have sensitivities to dairy, might feel very sick and unwell when they start taking some probiotics. Using turmeric will negate that. But it has to be in the right form. It has to be in a phytosomal delivery system. And my all favorite bioflavonoid is quercetin. So I describe quercetin as a bioflavonoid on steroids because it's so powerful in what it does. And here we can see the link once again between the gut and the brain, and how when there is activation of the HPA axis, it drives inflammation. So gut joint, so this is an article that refers. So if anybody really wants to read more and more about the gut joint interaction, and we can see here how the gut microbiota immune brain axis works, how dysfunction in the gut, permeability in the gut has been linked to Alzheimer's disease, autism, ADHD, anxiety, depression, schizophrenia, MS, because we know that long-standing inflammation ultimately becomes autoimmune, and MS is certainly one of the more common autoimmune diseases, and we know that autoimmune disease is on the rise in the United States. So the use of probiotics, and this is a question that I get asked all the time. So let's talk a little bit about probiotics. So lactobacillus and bifidobacteria are the most common. They're lactic acid producing bacteria. They usually don't colonize very well in where they need to go in the gut. They usually get broken down in the stomach. There's hundreds and hundreds of papers, but they're linked to helping with allergies and irritable bowel, anxiety. They help reduce biofilms, bacterial overgrowth or SIBO. Certainly in many patients, I'm beginning to do more and more microbiome testing of the mouth, and seeing different types of pathogenic bacteria, especially for people who have ongoing dental problems. More and more dentists are starting to do this work. A soil-based probiotic, which I think is the product of choice, because this will cultivate in the gut. It'll go where it's got to go. The reason it's called a soil-based probiotic, because it's usually surrounded by some type of spore. The spore gets digested in the stomach, and the good bacteria, or the bacteria, can go to the gut and colonize where it should. It's more of a bacillus strain, reduces inflammation, improves leaky gut, helps with intestinal irritable bowel syndrome, certainly with constipation, bloating, diarrhea. So this is my choice to use a soil-based or bacillus spore type of probiotic, and Saccharomyces boulardii. So Saccharomyces boulardii is produced from yeast, and it's one of those things. It's equal to nystatin. It helps kill off a lot of pathogenic bacteria. It improves secretory IgA. This is the thing you want to recommend to patients when they're traveling, because Saccharomyces boulardii prevents pathogenic bacteria from adhering to the lining of epithelial cells in the digestive tract. Now, the question that's always asked in terms of dosing, you can take them anytime. Doesn't matter with food, without food. You can take them definitely with antibiotics. You don't have to wait. We know that antibiotics are really very non-selective. They'll kill everything. There are patients I have had or I have started on taking all of them. A regular probiotic, a spore-based, and Saccharomyces boulardii, and you slowly work up and see in each patient what works better. And if you're just using, let's say, a soil-based, a spore-based probiotic, it's a good idea over time. I usually use 5 to 6 months to switch either products. And I think this is a big issue now, that there is so much research going on the type of family of bacteria that will do the best for each kind of problem. Meaning I have a probiotic for the nasal cavity, a probiotic for the skin, a probiotic for the gut, a probiotic for patients with sinus infections, bladder, and it's becoming that much more in vogue in terms of using not only probiotics, but the right families of bacteria. The dosing, maximum at least 4 weeks, up to 6 months, and you slowly have to see with the patient how they're responding and how they're doing. So we know the adrenal glands play a very, very important role in this gut-brain axis or in stress, because ultimately there's going to be a signal sent to the adrenal glands via the pituitary gland and ACTH, adrenal corticotrophic hormone, ACTH, excuse me, to release either an adrenal hormone or a cortex-driven hormone. And we know that the adrenal glands are on top of the kidneys. They're sometimes referred to as the suprarenal kidneys. The thing that's important is to not get caught up in this idea like years ago when everybody had adrenal insufficiency or adrenal hypoxia. And the only way you could treat these patients was to support their adrenal glands with certain nutrients, and that should be the core. There have been articles published on adrenal gland function, and more importantly, just treating the adrenal glands in patients with long COVID. We should begin to recognize that the adrenal glands are a gland within a series of lots of different glands and lots of different systems in the body. So we know that the adrenal cortex produces cortisol, the adrenal medulla is adrenaline and norepinephrine, which are involved in the body's fight or flight response. And of these, the most damaging is cortisol. And this is something for you to test in your practice. It's a saliva test. And why do we use saliva? Because when you're doing blood tests on hormones, you're not getting the full amount, the true value of the hormone, because a hormone is bound to a protein. And you can test just about every hormone in saliva except for THS, T3, and T4. They're too large of a molecule. And it's a lot easier when you want to look at a person's adrenal stress response and looking at their cortisol levels over 24 hours to have the patient produce cortisol, to produce saliva, because most patients can produce saliva very easily by just chewing on like a piece of gauze, which I think a lot of the labs actually include to produce saliva. It's easy to collect. It's easy to ship to the lab. The patient doesn't have to go to the lab 4 times in a 24-hour. And you can very effectively see what the person's response is. So we know that adrenaline and noradrenaline is part of the fight or flight response, which we've gone over, and it does a lot of different things. It controls blood pressure. It's a big player in cardiovascular health. All of the systems. So as we can see in this slide, 75 to 90% of human disease is related to stress and inflammation. So that's a key thing to understand and to put into your clinical database, that stress feeds inflammation, including cardiovascular and metabolic disease, which should not surprise anyone. And in this chart, we can see how stress is a leading cause of increased cognitive, emotional, behavioral dysfunction, cardiovascular problems, immune problems, meaning as your immune response goes down, you have an increased risk for autoimmune disease. Remember, I talked about this relationship between Th1-driven T helper cells and Th17-driven helper cells. When you lose the feedback mechanism, when Th1 goes down, Th2 goes up. You get increased levels of circulating cytokines, this low-grade chronic inflammation, and you increase your incidence of developing cancer, diabetes, Cushing's syndrome, which is hypercortisolemia, and certainly obesity, which drives inflammation. So here we have the HPA axis. You can see the relationship in the brain between the hypothalamus, the pituitary, and the adrenal glands. The pituitary produces adrenal corticotrophic hormone. Cortisol is released, and that activates the sympathetic nervous system. So we know that the consequences of HPA axis dysfunction, you can read them for yourself. It shouldn't surprise anyone. Major depressive disorders, anxiety disorders, diabetes, autoimmune disease, metabolic syndrome, cardiovascular disease, all driven by alterations in HPA axis dysfunction. When exposed to physical, environmental, or social stressor, the HPA axis is activated. That's the gasoline, the fight or flight response. Glutamate, which is an excitatory neurotransmitter, and norepinephrine are released. The hypothalamus releases corticotrophic releasing factor, and arginine, vasopressin to stimulate the anterior pituitary to produce ACTH, and that has an impact, obviously, on the adrenal glands. I've already said that glutamate is an excitatory neurotransmitter, and GABA is an inhibitory. So when you have this, it's almost like cortisol and DHEA, but GABA and glutamate fighting one another. Whoever wins out that will be the response of neurotransmitters. It may indicate the usefulness of emotion regulation. So anything that involves dealing with your emotions, contemplation, prayer, meditation, all of those things will have an impact. Sustained HPA axis activation causes high levels of CRH, which causes a blunting of the ACTH response. So it all comes down to the more the HPA axis is stressed, the more gas, you don't have enough brake, which is the vagus nerve, the parasympathetic end. So exaggerated elevation of cortisol during exposure to acute stress increases the sensitivity to NMDA receptors, which makes you more vulnerable to more stress and more excitatory responses. So the response of an individual to stress depends not only on the stressor, what's causing the stress, but factors specific to the individual. That's why it's so important to take a good case history and really delve into their background as to so physiological changes that would result in low cortisol output, changes in the ratios, obviously then in estrogen, testosterone, progesterone can affect lower levels of serotonin, the feel-good neurotransmitter that calms you down and lets you go to sleep would be a result. This shows in simple form the HPA axis, which is once again the sympathetic part of the autonomic nervous system, and that the short-term response to stress would be an increase in heartbeat, blood pressure, the hair on the back of your neck sticks up, you sweat, and that ultimately leads to more cortisol or more corticosteroids, and that leads to inflammation being reduced because you're having more cortisol, meaning more corticosteroids, which leads to a bunting of the reaction. It affects muscle tone, volume, blood pressure, and you can see on the right the adrenal glands and where different hormones come from which section of the adrenal glands. Now, this is something you can do in your office. I do it on a routinely in those patients that I suspect I want to delve deeper into their stress response by doing a adrenal stress index test, including you have to make sure that the lab that you use does a cortisol awakening response, because you really want to see within the first half hour or so. So cortisol and testosterone are the only two morning hormones. When you get up in the morning, your cortisol levels should be at a certain level, and within the first half hour should go up 50%, and then you get a normal circadian rhythm. So you want to see what's happening in the morning, and if your cortisol levels are going up by 50% and then dropping down to normal. And that's what's called the cortisol awakening response. So what does the cortisol awakening response tell you? If it's exaggerated, if it goes up too high, there's an anticipation of stress. There's an overreaction or an overactivation, I should say, of the HPA axis. People with high cortisol can't get to sleep. Certainly, in response to that being high cortisol, there's going to be low glucose. So these are patients that used to be labeled as functional hypoadrenia and low blood sugar. These are patients that are dealing with chronic stress. If there's a blunted, you don't have enough of the cortisol awakening response. It doesn't go up by 50%. These are patients suffering from chronic fatigue, and they're burnt out. There's so much stress on their HPA axis. There's so much dysfunction. When there's a low cortisol, these are patients that are going to crave refined carbohydrates and sugar. So there's going to be weight gain. And these are patients that a large percentage of them are dealing with post-traumatic stress disorder, which once again can be the result of one very stressful experience or cumulative over time. So in these three charts, you can see what happens to someone in terms of acute stress, chronic stress, and then really traumatic, post-traumatic stress. Where you see on the right side, there's a stressor. The sympathetic nervous system kicks into gear, but ultimately you have enough resiliency so that the stress response goes down and normalizes because you have this equalization of the sympathetic nervous system and the parasympathetic nervous system. Whereas in a chronic stress response, you see the stressor, the cortisol response goes up. There's a strong cortisol or sympathetic nervous response, but there's not enough parasympathetic. You have more gas than brake. And over time, that just really burns out the individual and burns out the ability of the stress response. And in someone who's had a very traumatic response to stress, their sympathetic and parasympathetic nervous systems are all over the chart in the sense that their cortisol levels are spiking. There's an over parasympathetic response to compensate, and you're just going through these like a roller coaster, these hills and valleys, which is someone that has severe HPA axis dysfunction. So what are the differences in cortisol? Well, we know that women tend to develop more autoimmune disease, but they certainly have a greater morning cortisol awakening response, especially they respond differently to trauma than men, especially if there's a repeated stress exposure. social stresses, Antarctic expeditions, and higher morning cortisol. So if you go anywhere with very cold, you're going to have a really severe uh, cortisol response, which you would suggest, whereas men have a higher uh, cortisol response, especially if they've been diagnosed with post-traumatic stress. They respond differently to pain, and something that you would think would be positive. So it's not so much something that's good stress or bad stress, it's how does your body respond to it. There's certainly higher cortisol in males as it relates to taking tests. And certainly one of the most stressful situations has always been labeled as public speaking. I mean, that's the number one thing that people want to avoid. I remember in high school, we had a class in public speaking, and I remember the first time doing that. And for any of you who have done public speaking, several years ago, I lectured at the A4M, the American Academy of Anti-Aging Medicine, and there were 7,500 doctors in attendance. And if that doesn't alter your stress response for a while, but then again, that's a good thing. There are times to be in sympathetic dominance. There are times to be in parasympathetic dominance. I mean, at night, you want to be in parasympathetic dominance. You don't want to be in sympathetic where you're getting this rush of cortisol, because then you're not going to be able to. So on this slide, we're looking at nutrients that will help with general support of the adrenal glands. Nutrients to support cortisol synthesis. Remember, cortisol is secreted by the adrenal cortex, so things like vitamin C, B5, licorice root, which is an adaptogen for modulating the stress response, adaptogenic herbs. So an adaptogenic herb is an herb that kind of senses how to bring anything back into homeostasis. So usually you're talking about ashwagandha and rhodiola root as being the primary adaptogenic herbs, phosphatidylserine and magnesium. As a note, there are multiple forms of magnesium. Magnesium is essential for mitochondrial function and energy metabolism in general. Energy drives about 700 different genes in the body. It's just a question of using the right form, which is either going to be magnesium citrate or magnesium glycinate, especially if people are sensitive and have issues with their bowel. Maybe you want to use magnesium glycinate. It's a natural muscle relaxant. And then you have magnesium threonate. So magnesium threonate is the only form of magnesium that crosses the blood-brain barrier. I believe it's 144 milligrams of elemental magnesium. It's sold under the proprietary name of Magtine. For energy production, coenzyme Q10, B vitamins, and L-tyrosine. And we could spend all day just talking about antioxidant protection. So things like turmeric, quercetin, omega-3 fatty acids. Vitamin D is an antioxidant. It also supports your immune system tremendously. Boswellia, which is it's an Ayurvedic herb. And most of the pycnogenol, grapeseed extract, melatonin, resveratrol. These are all very powerful antioxidant nutrients. So in this slide, it shows the unit that I use now, which is called VR Relief by a company called Hulist. The reason I chose this is number one, the cost. There are many vagal nerve stimulators out there that are very expensive not only to purchase the unit, but then you have to pay for the number of charges when you're using the unit. And this is a product that's under this unit, which is very lightweight. It's about the size of a credit card. I personally have one and have used it. It comes in the use of 5 different modes for relaxation, for stress, etc. And the treatment time is 5 minutes. And I have patients doing 5 minutes 3 or 4 times a day, whereas the previous treatment was using a TENS unit. And like I said, that's only affecting 2%. Here you're affecting over 98% of the vagal nerves in the body. And this is an article that shows the anti-inflammatory properties. So remember I said the vagus really has 2 effects. It's an anti-inflammatory, and at the same time it works on the immune system. So recent data has suggested that there's an anti-inflammatory role of the vagus nerve. One theory is that the anti-inflammatory role of the HPA axis, which is stimulated by vagal afferents and locals in the release on the adrenal glands. And the second one is, as I said, it has an affinity for receptors on macrophages. So it has an immune effect and an anti-inflammatory effect by doing this. Now, some of the ways to check the vagus nerve is by the patient opens their mouth and you can see the uvula, depending upon the positioning, if it's to the right or to the left or lifted up, that's usually a sign of some type of problem with the vagus nerve. So that's an easy test to check. And these are some of the exercises that I give patients to do in my office. Here you can see the person is laterally bending their cervical spine and they're holding against their head moving. But if you also notice, they're holding it and with their eyes, they're looking up at the ceiling, one on the right and then up to the left. And you hold this for about 30 seconds on each side. And I usually have the patient do this about 5 or 10 times. You can also massage the ears. There are certain pressure points. I've never really done this with patients. This is more into like auriculotherapy and looking at if there are points on the surface of the ear that when stimulated can have an impact. But this is the most common, the next few exercises that I'm going to show you. The patient is lying on her back, has her hands behind her head. She's looking up, but she's rotating her eyes, so she's looking up at the ceiling, taking in a deep breath and holding it for 30 seconds. The patient is then doing the same thing, holding their breath for 30 seconds and looking up to the ceiling to the left. Usually I have patients do this at least 5 to 10 times, several times a day, and they will notice if they're doing it properly that they will feel a difference. They will release a sigh and say, wow, I really feel more relaxed than before. So this is certainly something that you can use with your patients. But what else can you do? Tell the patient to avoid extreme diets, considering using probiotics. We went over that. So that can either be a spore probiotic, which I would recommend, as opposed to an acidophilus or bifidobacter type of culture. They should eat vegetables and foods that are high in omega-3s, and of course follow a more plant-based diet. Practice yoga, meditation, anything of mindfulness, prayer, breathing exercises, engage in physical activity, laughing, singing, humming, washing or sprinkling your face with cold water. You don't have to do a cold water soak or like the bucket challenge that they had for ALS, but certainly cold water seems to have an impact on the vagus nerve. And some other nutrients that might be helpful with the vagus, curcumin. So this data indicates that curcumin directly activates the vagal nerve, helps to release acetylcholine, which is the major anti-inflammatory parasympathetic neurotransmitter. Ginger and the vagus. This study provides evidence that ginger constitutes the constituent directly activates the vagal afferent nerves going away, C5 and peripheral to gastrointestinal, how these can help the vagus nerves that supply the gastrointestinal tract. So, so here we see the benefits of using ashwagandha. Now, ashwagandha is an adaptogenic herb. It's usually found in most products that address HPA axis dysfunction. So various vitamin companies, I know use a product HPA Select by Moss Nutrition, which has ashwagandha in it and rhodiola root. And it affects the hypothalamic pituitary adrenal axis, and it also addresses the sympathetic adrenal medullary axes, all involved in monitoring stress. So I wanted to talk now about the role that stress has on our immune system. And I wanted to start with this slide so that we're all on the same page in our understanding of the different parts of the immune system and how they work and how they can be affected by stress. So there are two basic components to the immune system: the innate immune response, which is predominantly, as I said previously, barriers, whether it's in the skin, lungs, brain, gut, inflammation, the complement system, hydrochloric acid, tears, very non-specific, very fast acting, because it responds usually to some type of trauma, whether that's physical trauma or some type of pathogen. So it's going to be responding very quickly, and it has a number of different types of cells within the innate immune response. Things like neutrophils, which go into an area where there's been some type of trauma or inflammation first, after neutrophils do what they do, because once again, there's permeability in the blood vessels, so they can squeeze through these openings and get to the inner portion of the blood vessel, the glycocalyx. Neutrophils then call in dendritic macrophages. Macrophages do what they do, and they pass off the information to dendritic cells, which take the information into the lymph nodes, and that's where a decision has to be made as to what type of immune response there's going to be. Is this going to be a full-out cloning of 10 to the 6th power of immune cells, or is this something that's only requiring, foot soldiers to manage this? So as I said, the key components are physical barriers, the skin, the mucosa, the complement system, and once again, very fast acting, no memory, as opposed to the adaptive immune response, which is slower, but it's more over time, has memory. The cells are more antibodies, cytotoxic cells, T helper cells, and once again, the adaptive immune system is more for neutralizing viruses, producing antibodies because of T cells and B cells, and killing infected host cells. The cells are different. There are T cells and B cells. Most people, when they think of the immune system, they're talking about the adaptive. So this chart shows a comparison between the innate immune response and the adaptive immune response. So the response time I said is almost immediate, because you're affecting receptors on the surface of the skin. There are a whole group of different types of receptors, but the number one group are called toll-like receptors. In adaptive immunity, the response is delayed. The specificity, once again, non-specific because there's no memory in the innate immune response. Very specific via T cells and B cells. There's no memory in the innate immune response. Present in the adaptive, the key cells are macrophages and natural killer cells. Um, and in the adaptive immune response, B cells and T cells. The main receptors are pattern recognition receptors or toll-like receptors. These are on the surface of cells, and they're like antennae that stick up when it comes in contact to something. Usually it's some type of pathogen that activates an immune response, whereas in the adaptive immune response, it's more antigen antibody in nature. This slide shows how stress affects the immune system, both the innate and adaptive immune responses. We know that as people get older, their immune system isn't as powerful because you have this shift of a Th1 type of response into a more Th2. So Th2 involves infections in hollow spaces, and you're losing the T cell responsiveness that would deal with pathogens. And as a result of that, you drive more autoimmune disease. And we know, number one, inflammation feeds autoimmune disease, but at the same time, it impacts the fact that autoimmune diseases take time to develop. You can figure anywhere from 20 to 30 years when someone's dealing with low-grade inflammation that it progresses towards an autoimmune disease. You see that stress affects the HPA axis and affects the sympathetic nervous system, and the more glucocorticoids are produced over time, you kind of lose that effect of cortisol as an anti-inflammatory. So you can see on the chart, there's an increased susceptibility to infections, not to mention what we see now in many patients who have had COVID. There's a reactivation of viruses as a result. There's a slower recovery time from illnesses and surgery. There's more of a risk of autoimmune flare-ups, and most patients don't have just one autoimmune disease. They may have several, as I've pointed out before, and that it's a potential contributor to chronic inflammatory conditions. Stress leading to inflammation, leading to chronic inflammation because there's no resolution of the inflammatory pathway. So this is a quick study guide that'll give you information to help you determine if your patient is in a more Th1 dominant or a Th2 dominant immune response. So remember, Th1s have to do with killing very small things like bacteria, fungi, and bacteria, whereas a Th2 response is driven by extracellularly and large things that need to be phagocytized. You can see the primary role of a Th1 response is more cell-mediated immunity, whereas a Th2 response is more humoral immunity. And you can see the pathogen type. One is intracellular, the other is extracellular. The types of cells, the antibody class that's created, one is IgG versus IgA and IgE, inflammation. It's pro-inflammatory, and the other is anti-inflammatory. And of course, the real issue is that a Th1 response, when it's high, has a complete negative feedback on Th17 types of responses. So if you lose Th1 tolerance, then you're driving Th17 and you're driving more autoimmune disease, whereas a Th2 response is more involved in inflammation in hollow spaces. So patients with asthma, allergies, irritable bowel syndrome, vaginal infections, bladder infections. Those are all Th2 driven. So a lot of practitioners ask me what supplements can they use that will help support a Th1 response versus a Th2 response. So I put this little graph together, this slide that shows that a Th1 response requires vitamin D, zinc, omega-3 fatty acids, B vitamins, especially B6 and B12, selenium, and probiotics, whereas a Th2 response is more vitamin A, vitamin C, omega-6 fatty acids, magnesium, probiotics, certain strains, and zinc. I would also sense that for the most part, Th1 responsiveness to enhance that would be berberine and sulforaphane that I didn't put on this particular chart. So let's talk about what happens to the brain, since the brain has its own immune response. And when there's inflammation, when I said there's enough inflammation, it activates the macrophages in the brain called microglial cells. And microglial cells, once again, are the macrophages of the brain. So you have two types of cells in the brain: those that are microglial cells, which are part of the innate immune response, and astrocytes, which really is the glue that holds synapses together. It helps to maintain the blood-brain barrier, and it helps to just keep all of the tissue of the brain together. So when microglial cells get activated, they can go into two different phenotypes. One is a pro-inflammatory, which is labeled M1, and you can see the type of cytokines that are released. It also releases reactive oxygen species. So I have to go back and fix this slide. M2 state, which is anti-inflammatory, and the proper cytokines like TGF beta, certain growth factors, and IL-10 will be produced to act as an anti-inflammatory response. So M1, pro-inflammatory, the outcome will be neuronal damage, chronic inflammation. You can see the cytokines that are released, reactive oxygen species and nitric oxide, whereas M2 is anti-inflammatory and repair. So you're releasing growth factors and you're leading to or subsequent tissue repair, inflammation. So the things that we talked about in order to maintain the integrity of the blood-brain barrier, which we'll talk about, is very, very pro healing of the brain, more an M2 type of response, and certainly is involved more and more with the repair of the blood-brain barrier. So what's causing the breakdown in the blood-brain barrier? A depletion of ATP, so mitochondrial dysfunction, increased acidosis and inflammation, oxidative nitrosensitive stress signaling, so you're producing more free radicals, infections, and leaky gut, and in parenthesis, leaky skin. So we know when there's permeability, there's an increased permeability that allows pathogens, things like LPS, to cross the gut barrier, stimulate the nervous system to produce pro-inflammatory cytokines. Also, another thing that would be of interest for those of you who treat athletes who have had concussions, and certainly patients who have had traumatic brain injuries, leads to a more M1 phenotype. So you have blood-brain barrier dysfunction that's associated with an increased permeability, and the same concept as in the gut, in the brain. The permeability allows immune cells, inflammatory cytokines, and viral and bacterial particles to enter into the central nervous system. And the most common complaints that patients will present with is brain fog, as I said previously, chronic fatigue, motor delay or clumsiness, anxiety, depression, and personality changes. So really the big four when you're talking about blood-brain barrier dysfunction and neuroinflammation are cognitive decline, brain fog, anxiety, depression, and fatigue. So what are the triggers of microglial activation? We've already talked about infections, toxins, chronic psychological stress, which drives cortisol, traumatic brain injury, gut-derived endotoxins, especially LPSs, lipopolysaccharides, aging, or as it's referred to now, inflammaging, which is really a combination of aging and inflammation put together. That one of the hallmarks or several of the hallmarks of aging is a reduction in the adaptive immune response, the inability to deal with inflammation. And we know as people get older, they become more inflamed. And obviously, neurodegenerative diseases like Alzheimer's disease, Parkinson's disease, and MS are all consequences of microglial activation. So what are some of the biomarkers? And it appears that we're moving or shifting more towards using these biomarkers as opposed to doing blood chemistries. I mean, certainly most practitioners start off with CBC, urine, SMA21, doing those kinds of tests, but there are very specific blood-brain barrier biomarkers that you can use in your practice. Obviously, high-sensitivity C-reactive protein, but once again, that's a general marker of inflammation. And high-sensitivity C-reactive protein greater than 3 milligrams per liter indicates a high cardiovascular and cognitive risk. Usually this will be found because these are patients that have MTHFR, SNPs, and that leads to an elevation of homocysteine because there's inadequate methylation taking place. ESR, a SED rate, but once again, this is not specific. It just says there's inflammation. Interleukin 6, well, this is a nasty cytokine. It's a pro-inflammatory cytokine that drives inflammation. It's a driver of frailty, and the higher IL-6, if you remember back in the graph, when we looked at low-grade inflammation versus chronic ongoing or acute inflammation, how TNF alpha, interleukin 6 would be very high and then come down in an acute case, but would stay elevated in a chronic inflammatory. TNF alpha, it's a master regulator of inflammation. Fibrinogen, which I certainly encourage you more and more and more to do in your practice because it's a blood clotting factor. And certainly we know now, since inflammation starts and creates permeability in blood vessels, inflammation of blood vessels is a very prominent underlying theme in most chronic disease, and in particular, long COVID-19. So in long COVID patients, it's very common to see individuals have strokes, and using things that will reduce fibrinogen. There's a lot of interest now in nattokinase and how it relates to lowering fibrinogen levels, and lipoprotein associated phospholipase A2. Now, this is not something that I mention in my practice or measure. Certainly in SMA21 CBC urine, I do TSH, T3, T4, high sensitivity CRP, I do a SED rate, vitamin D, red cell magnesium. These are all things that you can do on a pretty regular basis on just about every patient to get a good idea in terms of their overall health status. So what are some of the compounds that'll help control microglial activation? Turmeric, curcumin, because it inhibits M1 activation and promotes a more M2 phenotype. And you want to look at the label of the bottle and make sure the proprietary blend is Mariva. It'll say that. Resveratrol, which I don't use a lot in my practice, but I have used it, It reduces pro-inflammatory signaling. Resveratrol comes from red grapes. Omega-3 fatty acids. So omega-3, and remember you can do this test in your office, it shifts microglial M1 cells towards a more M2 phenotype. Green tea, EGCG, decreases oxidative stress and inflammation. Stearolinide is a neuroprotective antioxidant. Quercetin, which is my favorite, because it's not only a powerful antioxidant, but it blocks NF-kappa B activation. Vitamin D, which modulates the innate immune. Remember, every part of your immune system is dependent upon vitamin D. Most people think about vitamin D only as it relates to bone health, but vitamin D does reduce inflammation. It modulates the innate immune response. It helps protect, it's not just vitamin D, it's the vitamin D receptor. So if you're doing or giving patients vitamin D and their levels are not going up, and you should only check them maybe once a year, it's not the type of thing you put them on vitamin E and you check them all the time. You should put them on vitamin D. And there is a company called Grassroots, which you can get online, and they have a chart where you can determine based upon the level of your patient's vitamin D. Once again, you're measuring 25 hydroxy vitamin D, how much vitamin D you have to give them to get them to a level that you want. It's always been thought of that 32 nanograms per milliliter is probably the kickoff point, that once you can get above that threshold, you're actually having a benefit physiologically. Certainly, I want to get my patients up to the 50-60 range. And I strongly recommend at least 5,000 IUs a day of vitamin D. So here this slide outlines the flow of events showing how systemic inflammation can damage the blood-brain barrier. So you have chronic systemic inflammation. It's up to the clinician to find out what's causing the inflammation in the first place. That produces certain cytokines, which are very pro-inflammatory. You increase oxidative stress. You activate more what are these adhesion molecules. If you remember in the slide where I talked about inflammation, the first step in the inflammatory process is these adhesion molecules that attach to the inner surface of blood vessels, ultimately leads to permeability in blood vessels. You get activation of certain enzymes, MMP9s, that start to break down these tight junctions that exist in the walls of the blood vessel, just as it would be in the gut. You get increased blood-brain barrier permeability, and that permeability leads to ultimately neuroinflammation and ultimately cognitive decline. So we want to focus on the role that magnesium plays. Now, obviously, there are all different forms of magnesium. Magnesium drives at least 600 or 700 different metabolic reactions. This is something that the majority of your patients are probably deficient in. You cannot test it by doing serum testing. You have to look at red blood cell magnesium. But here you can see what begins to happen when a patient is low in magnesium, especially since it drives ATP production in the brain. So symptoms such as fatigue, irritability, mild anxiety, headaches, upset stomach. It has a profound impact on, because it's a natural muscle relaxant, it promotes relaxation of muscles. It decreases the stress susceptibility. And this is a very vicious cycle, how stress drives down levels of magnesium. It's a very overlooked mineral, only used per se a lot of times when people have diarrhea, because it relaxes the intestinal wall. So this is an article taken from Nutrient Magazine, Magnesium Status and Stress, the Vicious Cycle. So magnesium deficiency and stress are most common conditions among general populations, which over time can increase the risk of health consequences. Numerous studies, both in preclinical and clinical settings, have investigated the interaction of magnesium and many of these key uh, nutrient molecules and mediators of inflammation. They've demonstrated that magnesium plays an inhibitory key role in the regulation and neurotransmission of the normal stress response. Therefore, magnesium is very, very important in this whole question. And you can see from this chart symptoms of chronic stress, most frequently reported, and symptoms of magnesium deficiency. You can see the ones that are highlighted: fatigue, irritability, feeling nervous, lack of energy, upset stomach, muscle tension, headache, that very similar when you look at magnesium deficiency: tiredness, irritability, mild anxiety, gastrointestinal spasms, muscle cramps, headaches. And you see the difference where in uh, stress, sadness and depression, chest pain, hyperventilation. So magnesium plays a very important role in not only dealing with patients who have magnesium deficiency, which is going to be quite common, but then again with patients suffering from fatigue. It doesn't necessarily mean chronic fatigue, but fatigue. There are a number of different forms of magnesium. Here I just pointed out magnesium citrate, glycinate, threonate, and oxide, magnesium oxide. And as far as the absorption is concerned, you can see magnesium citrate has good absorption, but it has less targeting on the brain. There's only one form of magnesium that crosses the blood-brain barrier. That's magnesium threonate. It's best for brain penetration, and the downside is it's expensive. It's not as cheap as other forms of magnesium glycinate or magnesium citrate or magnesium oxide, but it's the only form. It's sold in a proprietary blend called Magtein, 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 and that's what you need to look for, and that's what you can order. It comes in 144 milligrams of elemental magnesium. So if you figure that you really should have your magnesium and calcium balanced 1-to-1, that you need 1,000 milligrams a day at least of magnesium, you're using 144 milligrams in the form of magnesium threonate. And you can see how magnesium threonate enhances synaptic plasticity, it reduces excitability, and it supports memory. This is something that I personally take, and I think in the right patient, I've seen some really interesting results in patients with migraine headaches, and generally, where you can tell from the history where they're experiencing cognitive decline, which is quite common in long COVID patients, that this would be a great adjunct nutrient in addition to giving another form of magnesium. So the treatment of magnesium L-threonate elevates the magnesium level in the cerebral spinal fluid and attenuates motor deficits and dopamine neuron loss in a mouse model of Parkinson's disease. So I think in any condition that you're dealing with neurodegenerative disease, which is the result of neuroinflammation, using magnesium threonate would be an excellent starting point in any protocol that you develop. So magnesium threonate, the full name is magnesium L-threonate. It was developed at MIT. Its primary benefit is it increases brain magnesium levels. Its main focus is cognitive enhancement. The typical dose is, as I said, 144 to 200. Most supplements are 144 milligrams of elemental magnesium. Bioavailability, it's very high for the brain, and the patent name is Magtein. So let's talk about strengthening the blood-brain barrier. I mean, obviously, from the work of Alessio Fasano, who I mentioned, gluten can be a main driver of inflammation, but the father of functional medicine, Dr. Jeffrey Bland, started with a 5R approach, which basically was remove the toxic load, re-inoculate the gut with good bacteria, repair the lining of the gut, replace any digestive enzymes, re-educate the patient, in terms of their eating habits, going on a more plant-based diet. Certainly the use of probiotics. And we talked about probiotics. There are so many different families of bacteria. These are the ones that have been shown to be effective: Lactobacillus paracasei, Lactobacillus acidophilus, bifidobacteria. Obviously, if you suspect or you do testing in your state for toxic metals, so things like glutathione, which is a major chelator, alpha lipoic acid, polyphenols, omega-3 fatty acids, zinc are all helpful for detoxing heavy metals out of the brain. Acetyl L-carnitine, alpha lipoic acid. My favorite new guy is berberine because it blocks the activity of these enzymes that break down the blood-brain barrier. It especially reduces inflammation in brain injury. You're probably going to hear a lot about berberine because it has a profound impact on controlling blood sugar, but it also drives a more potent Th1 response. Turmeric, remember it should be in a phytosomal delivery, and the proprietary name is Meriva. It increases the concentration of tight junction proteins in the brain, decreases brain swelling, and prevents disruption of the blood-brain barrier by increasing NRF2. So NRF2 is derived really from sulforaphane. So it's very important for recycling antioxidants because you're generating so many free radicals on every second that what this nerve pathway cycle does is it helps the body regenerate antioxidants that have been used up, and it helps to recycle them so you get more use. So the more you can supplement with NRF2, which is derived from sulforaphane, you can eat a diet, once again, high in substances that contain very high amounts of NRF2, like broccoli and spinach and parsley, and certainly taking antioxidants, all to improve the antioxidant status within a patient. Vitamin D3, which I think is crucial, and everybody should be taking vitamin D3. As I said, sulforaphane, it blocks the breakdown of permeability by inhibiting these enzymes. Omega-3 fatty acids, because omega-3s are very important for cell membrane function. Resveratrol reduces inflammation and restores the integrity of the blood-brain barrier. And these pro-resolving mediators, or SPMs, here they're referred to as PRMs, but pro-resolving mediators, once again in the conversation or the slide on inflammation, they're 100 times more anti-inflammatory than fish oil. So in difficult cases, I do recommend the use of pro-resolving mediators. So when good guts go bad, when the integrity of the intestinal blood barrier is compromised, it has a potential effect on other organs. So gut dysbiosis leads to more inflammation, more neuroinflammation, more neurodegenerative disease. So starting in the gut is not a bad idea. Any interruption in the balance of microbiota can cause dysbiosis, sugar, antibiotics, infections, cleanses. Some people do a lot of detoxing. They don't do it properly. And of course, stress can drive inflammation in the gut. So we can see here, how does stress affect cardiovascular disease? Through a number of different ways. Stress activates the whole chain of events leading to inflammation. Inflammation can increase blood pressure. It can alter metabolic changes, which ultimately lead to cardiovascular disease. But stress elevates cortisol, and high cortisol drives more free radical pathology, depletes more vitamins, especially B vitamins, and in particular B6, B9, and B12. So B6, folate, and B12, which leads to elevated levels of homocysteine. So homocysteine is one of those markers that I should have mentioned that many of you, based upon the history, should be doing on your patient, especially if there's a history of cardiovascular disease. The patient presents with high cholesterol, low HDL, high LDL, you might want to consider doing an elevated homocysteine, looking at whether or not there's an elevated homocysteine, because that would look at methylation and if there are problems with methylation. So methylation helps to convert methionine from homocysteine. So if you're missing any of those B vitamins, B6, B12, and B9, folate, you're going to have a problem with methylation and ultimately have high levels of homocysteine. So how stress affects the cardiovascular system? A, it activates the HPA axis and the sympathetic nervous system, which leads to an increase in cortisol and catecholamines, adrenaline and noradrenaline. It affects increased heart rate, vasoconstriction of blood vessels, elevates certainly blood pressure, and there's an increased cardiac workload. Chronic stress promotes, which we've talked about, low-grade systemic inflammation, and these inflammatory cytokines like IL-6, TNF-alpha contribute to damage of the endothelial wall, the inner lining, the glycocalyx, causing leakiness. That inflammation can ultimately lead to the buildup of plaque in blood vessels. Oxidative stress and excessive reactive oxygen species can cause damage to blood vessels, lipids, DNA, promoting arterial stiffness, plaque formation, and increases the risk of thrombus. It can affect and create, since it alters blood sugar levels, dyslipidemia, insulin resistance, type 2 diabetes, and coronary artery disease. So what are some of the key causes of endothelial inflammation? Oxidative stress, high sugar, chronic infections. Remember I said that chronic infections, which would be called a PAMP, a pathogen-associated molecular pattern, drives inflammation, and the activation of the innate immune response will ultimately lead to damage of the endothelial lining of blood vessels, drives autoimmune disease, and autoantibodies can attack blood vessels. Hypertension, environmental toxins can drive heavy metals. We know there are issues with pesticides and pollution. Air pollution in particular has now been shown to be linked to high blood pressure, obviously more damage to the cardiovascular system, the respiratory system, people who live near highways, and just the noise alone, congestion, fuel emissions, etc., can drive inflammation. Poor diet, the standard American diet, smoking, alcohol abuse, and dysbiosis via LPSs, which are lipopolysaccharides. So markers, VCAM and ICAM, which you can measure in blood, MPOs, high sensitivity C-reactive protein, fibrinogen, MMP9. MMP9 is really involved in breaking down the extracellular matrix. So these are enzymes that break down cartilage. In my office, I really just do the high sensitivity CRP and fibrinogen in addition to some of the others that I've talked about. How to reduce endothelial inflammation? The Mediterranean diet, DASH diet. I mean, now there's been so much work done on plant-based diets and their effects on a whole host of symptoms relegated to not only inflammation, but cardiovascular disease. The use of omega-3 fatty acids, exercise, magnesium, vitamin D, coenzyme Q10. Now, there's a lot of controversy on different types of coenzyme Q10. If it's ubiquinol, or there is a company that sells something that they label as mitoquinol. So I think the jury is still out, although they do think that in certain cases ubiquinone is better. I've switched in my practice to using mitoquinol, which is which has been developed by a company in New Zealand, and they have a number of different products with the center of it being mitoquinol, which they claim is a better, highly absorbable form of coenzyme Q10. And certainly patients taking statins induce a coenzyme Q10 deficiency. And people, though, however, taking these drugs also develop fascial pain, muscular pain. And certainly we know that coenzyme Q10 is very protective of the heart, also seems to do a great job in protecting the brain from oxidation. Obviously, stop smoking, limit the alcohol intake, and support the functioning of the gut by using probiotics, fiber, reducing the load of endotoxins. So essential nutrients for health: omega-3 fatty acids, magnesium, vitamin D, vitamin C, vitamin E, coenzyme Q10, L-arginine, and citrulline. They're precursors to nitric oxide. They always refer to L-arginine as the poor man's Viagra because it's a vasodilator. So polyphenols like quercetin, resveratrol, curcumin, folate, B6, B12, especially you need to have the patient take it in methylated form to lower homocysteine levels, which I previously said. I use a product called B12 methylfolate. So it's supplying B12 in a cyanocobalamin form, and it's a methylated B vitamin. Since most patients, and you can do this, you can check their methylation status. So this shows in an opposite direction what happens when someone has a stroke. Well, it's activating their HPA axis. It's causing a surge in sympathetic dominance, which leads to a release of catecholamines. There's going to be definitely a strong correlation between gut dysbiosis, increased permeability, translocation of endotoxins. So when you think about intestinal permeability, think about how the permeability is being created. And as a result, you can see atherosclerosis, thrombosis. So you have cardiac dysfunction, inflammation, obviously. There's an immune response to the systemic inflammation. There are changes in the RNA, and there's damage done to the vascular tree. It's causing more and more permeability. So how does stress affect homocysteine? We talked about this before, this elevation that homocysteine in the presence of adequate amounts of B6, B12, and folate get methylated into methionine. So there's an increased demand for methylation. Chronic stress activates the HPA axis, leading to cortisol. Methylation processes consume methyl donors. As more SAMe, which is another methyl donor, is used, homocysteine can build up. Oxidative stress leads to impaired certain enzymes like methionine synthase, which is part of the whole process of getting rid of homocysteine. Stress depletes B vitamins, so the vitamins that are necessary to keep in check homocysteine levels. These vitamins are crucial cofactors in the metabolism of homocysteine. Low B vitamin status, high homocysteine. Inflammation causes or promotes low-grade inflammation and the production of these inflammatory cytokines that we've talked about. High cortisol, increased methylation demand, higher homocysteine. Oxidative stress affects the enzymes that are required to get rid of homocysteine. B vitamin depletion increases homocysteine clearance, and inflammation impairs homocysteine metabolism. So key nutritional support would be B6, folate as methylfolate, B12 as methylcobalamin. You can use betaine or TMG, which supports homocysteine remethylation. So methylation is happening all the time. It's the addition of a CH3 group, and it helps with maintaining the stability of cell membranes, the metabolism of hormones, lowering stress on cells, especially mitochondria. So homocysteine is a very nasty pro-inflammatory marker. Using antioxidants like vitamin C, vitamin E, glutathione, which happens to be my choice, not NAC. A lot of people supplement N-acetylcysteine because cysteine is one of the peptides that makes up glutathione. Remember, glutathione is a tripeptide. It's made up of cysteine, glycine, and glutamic acid. And cysteine is the rate limiting step, meaning if you don't have enough cysteine in your diet, you won't produce enough NAC. And even if you do, it will restrict the amount of NAC. So you might as well go right to the source and give glutathione, which you can give in what's called a liposomal delivery system, which enhances the absorption, L-glutathione. And that's found in a number of different ways. You can take it in liquid form. You can take it in capsule form, and it will say liposomal glutathione on the label. And you can take it in a spray. There's a vitamin company that sells L-glutathione in a spray form, and you just 2 sprays in the mouth is the equivalent to, I think, 500 milligrams. It depends on the patients. Some patients like the spray. I don't like it. It's got a lemony taste, but like a sour lemony taste. It's not sharp to me as a lemon. Some people like the liquid. I don't like the liquid, so I take capsule. Each to their own. So what's methylation, which we talked about again? It's a crucial, critical biochemical process where methyl groups are added to molecules. They're essential for DNA repair, detoxification, neurotransmitters for the immune system, all the things that I've previously mentioned. Where does it happen? In DNA methylation, lipid and protein methylation, neurotransmitter synthesis, and in detoxification pathways. So we're going to look at those nutrients that are key for methylation. Folate, especially in the form of methylfolate or 5-MTHF, vitamin B12, especially in methylcobalamin, B6, riboflavin, betaine or TMG, choline, which is a precursor actually to acetylcholine, methionine, which is a byproduct of homocysteine metabolism. This is where the body wants to go. It wants to take homocysteine and through a process of several methylations get to methionine, which can be utilized in the body, and magnesium, which once again is a cofactor for dozens upon dozens of enzymes in the body. Now, there are a number of different important enzymes that are involved in the methylation process. MTHFR, which probably has the most interest or has been written the most about, and certainly testing patients for MTHFR and seeing what the patient's SNPs are. Either they have the most common, which is the C677T SNP, or the C112, 128 SNP, and certainly that will have an impact in determining whether or not the person should be on a methyl B vitamin. COMT, which has to do with neurotransmitters, MSMTR, which converts homocysteine, methionine synthase, which converts homocysteine to methionine, and BHMT, betaine homocysteine methyltransferase, which uses betaine to methylate homocysteine. So it's all about methylating homocysteine into a form that the body can get rid of. What can go wrong? You can have undermethylation. You don't have enough methylated B vitamins. So those symptoms would include fatigue, anxiety, depression, poor detoxification, since methylation is involved in the second phase of detoxification or conjugation. If you have poor methylation, you're going to have high homocysteine levels. And we know that homocysteine is linked to cardiovascular disease. Overmethylation, too much methylation, irritability, anxiety, histamine intolerance symptoms, similar to mast cell activation. So genetic variations like MTHFR mutations can impair methylation. And this is the first thing that I look at in my patients when I do a genomic test, is look at the level of I look at MTHFR and see if they're heterozygous or homozygous for the two major SNPs of MTHFR. If they're heterozygous, that means their ability to methylate through that particular pathway is diminished by 30 to 40%. If they're homozygous for the MTHFR SNP, one of them, then over 70% incomplete methylation. And this is a very valuable piece of information to know in managing your patients. So what's the DASH diet? Dietary approaches to stop hypertension. So this has been looked at over the years, very similar to using a plant-based diet. It's a clinically proven eating plan that has been looked at to lower blood pressure. Its main focus is the food high in potassium, magnesium, calcium, fiber, and protein, and low in sodium, saturated fat, added sugars, and red meat. And a lot of this work comes from the work of Dean Ornish, who 40 or 50 years ago looked at plant-based diets in relationship to cardiovascular disease. And he noticed that those patients that did a plant-based diet, they were able to slowly reverse their cardiovascular disease in terms of deposition of plaque in blood vessels, which has really nothing to do with cholesterol. Once again, it's inflammation, damage to the endothelial lining of the blood vessel that acts as a nidus for inflammation. And as a result of that, that's when different fats can accumulate and deposit on the walls, making especially arteries work harder to pump blood. So what are the core principles? It would be obviously as a plant-based diet, fruits and vegetables, whole grains, low fat, dairy, lean protein, chicken, fish, lamb, veal, turkey, beans, nuts, seeds, legumes, fats and oils, sodium, and obviously reducing your intake of sweets and refined carbohydrates and junk food. So in conclusion, when we're addressing stress and health, the impact physiologically of stress on health is predominantly an activation of the HPA axis, which leads to an increase in cortisol, an increase in ACTH. You're increasing the sympathetic activity, the fight or flight response, and decreasing the parasympathetic side of the equation. Remember, the parasympathetic side is the vagus, so vagal tone, and certainly that can be addressed, which we've talked about. And chronic cortisol leads to immune suppression, insulin resistance, and catabolism. Instead of building up, you're breaking down. So how does stress or chronic stress, how are the different systems? We talked about the nervous system, anxiety, depression, brain fog, insomnia, the endocrine system, dysregulation of the HPA axis, and ultimately adrenal fatigue, the immune system, more increased inflammation, decreased immunity, digestion, IBS, ulcers, dysbiosis, altered gut motility, which is under the control of the vagus, cardiovascular system, hypertension, tachycardia, and atherosclerosis, musculoskeleton, increased tension, TMJ pain, fibromyalgia, reproductive system, irregular cycles, infertility, and low libido. What are the common things to monitor? Patients with fatigue, irritability, mood swings, sleep disturbances, appetite changes, headaches or muscle tension. We know that muscle tension headaches are a very common result of increased stress. GI symptoms, which I'm going to say you're going to see in a majority of your patients, have some degree of functional GI distress. Cognitive issues, memory, focus, decision making, all a result of increased systemic inflammation and ultimately neuroinflammation. Tools that you have, there are various stress tools that you can find online to evaluate a person's stress, and these are the types of assessment tools where you can gauge based upon life experience. Like the number one, the most stressful is loss of a loved one. You can do cortisol testing in saliva, you can do Dutch testing through urine, and you can do serum testing. You can look at, if you have a Apple Watch, you can look at heart rate variability. There are certainly rings that are available that people can wear, various types of questionnaires, and looking at the various inflammatory markers that we looked at, such as CRP, IL-6, the ratio of cortisol to DHEA. We didn't talk a lot about DHEA, but DHEA is an adrenal hormone. And in most of the labs that do adrenal stress testing, that 24-hour saliva test, they will give you a cortisol DHEA ratio because they kind of interact with one another. If there's high cortisol, there's probably going to be low DHEA. And DHEA is one of those, along with cholesterol, as a precursor molecule to hormones. What are some of the unresolved issues? Trauma. We talked about mental trauma, adverse childhood experiences, looking at things in the household, poor sleep hygiene, nutrient deficiencies, substance abuse, too much caffeine, chronic illness or pain, lack of social connections and support, circadian rhythm disruption, which is very common. People who work at night, they don't get a lot of light exposure. People who have shift works. So, what are some of the interventions that are involved in managing stress? Lifestyle, so regular exercise, sunlight exposure, getting consistent with when you go to sleep and when you wake up. Certainly mind-body, meditation, breath work, vagal nerve stimulation, yoga. We've listed a whole bunch of anti-inflammatory supplements, adaptogens, mainly ashwagandha and rhodiola, magnesium, and remember for blood-brain barrier, magnesium threonate, B vitamins, but they should be in methylated form, psychologically, cognitive behavioral therapy, trauma therapy, getting people to be involved in a community, connections, make friends, cultivating building strategies, cultivating purpose, gratitude, reframing your stress, exposure to controlled stressors, getting to understand that they are under stress and they're maladapting to the stress, and most importantly, spiritual practices, having a belief system. So I hope I've given you a brief overview of stress and how stress impacts so many various systems in the body, but more importantly, some of the things you can do in your practice in evaluating the patient who you feel is maladapting to stress or presents with some of these symptoms, how to go about testing, let's say, for intestinal permeability, understanding the role of the gut, understanding the role of the vagus nerve, understanding the concept of inflammation and autoimmune disease. And when there's too much inflammation, you ultimately develop neuroinflammation and ultimately neurodegenerative disease. So I hope some of the things that I've pointed out in the last 2.5, 3 hours will help you in terms of managing your patients and help you achieve better patient outcomes. So thank you, and we'll see you again for the next part of this 10-module course on functional medicine.